Hi, my name's Sean Williamson. I am a senior staff pathologist in the Henry Ford Health System and a clinical associate professor of pathology at the Wayne State University School of Medicine. Thanks for joining the conference today for this PathPresenter board review course. And it's really great to have the opportunity to sort of contribute to your education at this time. So without getting into much more, I'll start the slide seminar today. The first case, this case, it probably would help you to know that this is a renal mass in a young child, and it would probably help you even further if I told you that this was a congenital renal mass, so it was present at birth. And we can orient ourselves a little bit. There's a small amount of renal parenchymal tissue over here. And actually, if you look at this a bit, you can tell that some of the glomeruli are immature. So that would also be a clue if you were just handed this slide without knowing anything about the history that this is a young child. And then also something that can sort of orient you to this particular slide is that there is some brown fat adjacent to the kidney. So these fat cells are kind of more vacuolated than we would expect in adult fat. And so that might also be a clue that this is a renal mass in a young child, where children have usually more brown fat than they do, than adults do. And certainly around the kidney and in the retroperitoneum is a location where you can see brown fat. And so if we start looking at the mass, you can see there's this spindle cell proliferation with kind of a fascicular arrangement of spindle-shaped cells that are relatively monomorphic and cytologically not that atypical. And these infiltrate throughout the kidney, and they kind of go around and entrap normal structures like glomeruli and renal tubules. And so especially with this morphology combined with the clinical history that this is a young child, especially congenitally, I think those are all good clues to the diagnosis in this case that this is a congenital mesoblastic nephroma. And so congenital mesoblastic nephromas are the most common congenital renal mass, and they overwhelmingly occur in children that are under 2 years of age, and especially in the first year of life. Mesoblastic nephroma comes in two varieties. The classic type, which has a more uniform fascicular architecture with more cytologically bland spindle-shaped cells. And then the cellular type, which often has a greater mitotic rate, sometimes has necrosis, and basically is histologically identical to the entity infantile fibrosarcoma. And curiously, the cellular type of congenital mesoblastic nephroma and infantile fibrosarcoma share the same gene rearrangement, which is a rearrangement between chromosomes 12 and 15, so translocation 12-15, involving the genes ETV6 and NTRK3. And this is a really interesting gene fusion in that it's been recognized in several other tumor types. So we've got mesoblastic nephroma, we've got infantile fibrosarcoma which both share that same type of gene fusion. And actually, it's been recently recognized that a subset of inflammatory myofibroblastic tumors, instead of rearrangement of the ALK gene, which is the most common rearrangement in that tumor, also has this ETV6 NTRK3 fusion. So this is, I think, a pretty good example of a congenital mesoblastic nephroma in a young child. Now, please forgive me, I am a renal tumor enthusiast, but I'm not a pediatric pathologist. So if any of you are pediatric specialists and there's something that I've screwed up about this particular case, feel free to reach out to me. My contact information should be on the conference website. But from the standpoint of a GU pathologist and a renal tumor sort of nerd, I think this is a pretty good example of a congenital mesoblastic nephroma. But again, please feel free to reach out to me if I've made some horrible mistake here. The second case is a testicular mass. And so hopefully this is relatively straightforward, but you can see this area of very blue, high cellularity here within the testis. And if we zoom in to look at that at higher magnification, hopefully it's relatively straightforward that we've got the classic features of seminoma. And so you can see here you've got cells with predominantly clear cytoplasm, a sprinkling of lymphocytes that are admixed, for example, right here in the center and the top of the field. And the cells have prominent nucleoli. If you can make it out on this, at this magnification, this is the highest magnification we have on the slide, something that you'll often notice with seminomas is that the nuclei are often not totally round, but they're kind of rounded with squared off corners. So they're kind of like rounded box shaped nuclei, which is something that you can appreciate at high magnification in seminoma that can be a clue to the diagnosis. Also, sometimes in seminomas, you'll have exuberant granulomatous reaction, and sometimes that's so florid that it almost obscures the tumor cells. So if you have a testicular mass with tons of granulomas, think about the possibility of seminoma before you completely disregard that as just a granulomatous process, such as sarcoidosis or an infectious process. And something to keep in mind is that seminomas sometimes have cells that are not entirely clear. They don't entirely have clear cytoplasm. Like, for example, in this field, you can see that the cells actually have eosinophilic cytoplasm and very dark nuclei. So don't be dissuaded if you're thinking about the possibility of seminoma, but you see cells with eosinophilic or very dense cytoplasm rather than the classic clear cytoplasm. It still is very possible that that tumor is a seminoma. Now, this particular case, most of the adjacent testicular parenchyma is atrophic. So even at low magnification here, you really can't see much going on in the adjacent testicular parenchyma. Here is a small amount of the reedy testis, which is also present on the slide. And the reedy testis, we try to report involvement of tumor into the reedy testis in testicular germ cell tumors. It doesn't affect the tumor stage directly, so it's not one of the staging parameters, but some oncologists will use that as a surrogate for considering whether a tumor is higher risk, and they might consider treatment up front rather than surveillance following the orchiectomy. So in this case, I don't see any direct tumor involvement of the reedy testis by seminoma in this particular field. And something that you'll also see occasionally is that you can find germ cell neoplasia in situ within, spreading in a pagetoid fashion into the reedy testis. And I don't see that in this particular case either. But we'll look at an example of germ cell neoplasia in situ, or GCNIS, in the next slide in just a moment. But I think this is a pretty good example of a seminoma. Something that I often like to point out about seminomas is that although we think of germ cell tumors as being a tumor of young men, you can actually have seminomas at a fairly late stage in life. So even some patients are 60 or 70 years old can have a pure seminoma. Now, it would be uncommon to have a mixed germ cell tumor or a non-seminomatous germ cell tumor at that age in life, but it is possible. There's a small but significant fraction of men in the age 50, 60, and sometimes even 70 years old who have a classic usual type seminoma. So let's move on to the next case. Here's another testicular mass. And if we zoom in here, you can see this area with substantial necrosis and a cellular tumor adjacent to it. Before we look too much at that tumor, I would just like to point out the germ cell neoplasia in situ in the adjacent testicular parenchyma. And so this entity, the name has been changed in the most recent WHO classification. So the 2016 WHO classification of testicular germ cell tumors, the name for germ cell neoplasia in situ was changed. That was to accommodate basically the two different schools of thought for this entity. In the previous WHO classification, it was referred to as intratubular germ cell neoplasia unclassified. So that was often abbreviated as IGCNU. And other pathologists, especially those in Europe, often use the term carcinoma in situ for this entity. So carcinoma in situ is sort of a misnomer because germ cells are not epithelial cells. They're actually their own distinct cell type. And the flaw in intratubular germ cell neoplasia unclassified, or IGNU, is that by using that word unclassified, it almost implies that we don't know exactly what this is. But in fact, this is the most common and the presumptive precursor lesion to malignant germ cell tumors of the postpubertal testis. So it was thought to be somewhat misleading to have that terminology of intratubular germ cell neoplasia unclassified. And so germ cell neoplasia in situ, GCNIS, was agreed upon as kind of a new name for this entity, which combines the thought of carcinoma in situ with the previous name of germ cell of intratubular germ cell neoplasia unclassified. So GCNAS, germ cell neoplasia in situ, is the new name for this entity. And when you're looking for it histologically, a helpful clue is that the tubules that have germ cell neoplasia in situ usually will not have robust spermatogenesis. So just looking at this field, you can see that there's not much maturation with small sperm in the lumen of the seminiferous tubules. So if you see fields where there are abundant sperm in the lumen of the tubules, those are probably not the best ones to look at for a diagnosis of GCNIS. In contrast, this particular field has lots of cells that kind of pop out with their pagetoid distribution at the basement membrane of the seminiferous tubule. And if we look at those at higher magnification, hopefully you can make them out here. These cells will basically look like seminoma cells, except that they are arranged in a very specific anatomic distribution that is along the basement membrane of the seminiferous tubule, which is known as the spermatogonial niche. If you start to see filling up of the tubule more than just along the basement membrane, technically that can be diagnosed as intratubular seminoma. So when you have more than just the basement membrane layer involved, you can refer to that as intratubular seminoma. But right here at the center of the field, hopefully you can appreciate there's a cell with some large prominent nucleoli like those of seminoma. Basically I think all of these cells along the basement membrane with a very prominent clear cytoplasm are germ cell neoplasia in situ. Or for example, just to the right side of the field here is a cell with a prominent nucleolus. Or also in this center tubule, you can see some nucleoli. So if you see that pattern, that is supportive of a malignant germ cell tumor that's derived from the postpubertal pathway. And we'll talk a little bit about the prepubertal and postpubertal types of testicular germ cell tumors. But then if we look at the cellular tumor in this particular case, you can see that you've got this proliferation of cells that are very eosinophilic. They have less of the clear cytoplasm compared to the seminoma that we just looked at. And at least some of them have multiple nucleoli, in contrast to the usually single central nucleolus of seminoma. So this is an area of embryonal carcinoma in this patient. For example, here kind of in the center of the field is a cell with 3 nucleoli. Also with embryonal carcinoma, you often see more crowding and overlapping of the nuclei as compared to evenly spaced nuclei in seminoma. And I'll zoom around to show some different fields in this case. Here you can see a bit of glandular formation, which is fairly common in embryonal carcinoma. Here's some necrosis, which can be seen with multiple types of testicular germ cell tumor, but often present in embryonal carcinoma. And here again in this field, you can see there are some glandular formation, which is in keeping with the diagnosis of embryonal carcinoma. And if you spent some time looking around this slide as well, you might notice that there's also some seminoma in this particular case. If you go up to the top edge of the slide here, you can see there are some seminoma cells with the more clear cytoplasm, some of which are probably intratubular. As you can see here, there's a tubule that's probably filled up with seminoma cells, and others which are infiltrating into the stroma. If we go back over here again, you can see some glandular formations in the embryonal carcinoma. So embryonal carcinoma, again, a few takeaways are that it frequently has glandular formation, as you can see here, frequently has more nuclear overlapping and crowding, sometimes more than one nucleolus, and usually more of a basophilic appearance at low magnification, and it can have glandular, papillary, and multiple patterns. If you would like to use immunohistochemistry to help you distinguish between seminoma and embryonal carcinoma, both seminoma and embryonal carcinoma will usually be positive for the germ cell tumor marker OCT4 or OCT3/4. So that doesn't help you distinguish between the two, but if you're thinking of one of those diagnoses, that does support it. And then some markers that show different results between embryonal carcinoma and seminoma include c-KIT. So c-KIT or CD117 is usually positive in seminomas and usually not positive in embryonal carcinoma. Conversely, CD30 is typically positive in embryonal carcinoma and typically not in seminoma. So those are, in general, the markers that I think are pretty widespread, and many people have in their immunohistochemistry labs that would be helpful to distinguish embryonal carcinoma from seminoma. In addition to those, potoplanin or D240 also is frequently positive in seminoma, and that can be used to help distinguish those two. So let's move on to the next case. This case is again an embryonal carcinoma, and this has, I think, some interesting findings for discussion of staging of testicular germ cell tumors. So if we zoom in again on the tumor, you can see that there is this proliferation of cells, very basophilic at low magnification, sort of disarrayed nuclei, with many of them crowding and some of them overlapping and looking like the nuclei might even be touching each other. Something that you sometimes see in embryonal carcinoma is the so-called applique pattern, and you can see that here in this particular field. What that means is that you have your viable appearing tumor cells, and then you have these smudged cells with more of a smudgy chromatin pattern that look like they're kind of stuck on to the surface of the viable tumor cells. So that's referred to as applique, meaning that they almost looks like they were applied to the outside, you know, stuck on like a sticker onto the outside of the tumor cells. And the only importance of that is just to realize that that's something that happens in embryonal carcinoma, and not to let it fool you into thinking that this is the biphasic pattern of a choriocarcinoma. So these are not necessarily the trophoblastic cells of a choriocarcinoma. And again, if you have that differential diagnosis, OCT3/4 would be very helpful, as immunohistochemistry for OCT3/4 will be classically positive in essentially every cell of embryonal carcinoma, whereas it is usually not positive in the cells of choriocarcinoma. And so let's talk a little bit about the staging in this particular case. If we go to low magnification again, you can see there are these big round structures that are going into the testicular hilar tissue there. And I think actually in this particular case, almost all of these big rounded structures in the hilar tissue represent lymphovascular invasion, which is a way to reach the PT2 stage in testicular germ cell tumors. So some of these are probably actually quite large vessels that are entirely obliterated by the tumor. Here you can see there are several large open vessels, and then this cluster of large nests of tumor cells that are adjacent to it. In my interpretation, these are most likely large blood vessels that are totally filled with tumor and almost obliterated. But if you also look at some of the smaller blood vessels, hopefully you can make out here, for example, there's a small blood vessel which is open, and then right next to it is another plug of tumor cells, which to me is most likely in a vascular space. Or if we go over here, hopefully this is quite clear that this is a small vascular space and there's a plug of tumor cells within it. And so something to remember when you're thinking about the staging of testicular germ cell tumors is that these tumors are often very friable. Here again is another area with several clusters of tumor cells within lymphovascular spaces. And since these tumors are very friable, when you're cutting them in the gross dissection room, you might find that tumor cells spread kind of all over the place. And so if you're thinking about the possibility of lymphovascular invasion, look at the periphery of the slide. And if you see lots of tumor cells that are just smeared all over the place and every empty surface of the slide has tumor cells stuck on it, then you might be a little bit cautious about diagnosing lymphovascular invasion because you have quite a lot of artifactual tumor spread. But in this case, I don't see very much tumor that's spread onto the outer surfaces of the slide. So I think that gives even more support to interpreting these small foci as true lymphovascular invasion. And I think these would be very convincing even if we had a moderate amount of spread of tumor cells on the outside edges of the slide, just because these are nice cohesive clusters of cells that are conforming to the shape of the vascular space. They're not just loose aggregates of cells that are all over the place. So this is an example of embryonal carcinoma with attention to the lymphovascular invasion, which gets you to the PT2 stage in the current staging of testicular germ cell tumor. That's the AJCC 8th edition, which was released in, I think, 2016, I believe. And so in this field, also you can see the involvement of the retestis, like I mentioned earlier. So here, this kind of interconnecting glandular structure is the rete testis, which is a network of ducts which connect the seminiferous tubules to the epididymis and to the drainage system of the testis. And when you have direct tumor invasion into the rete testis, usually we recommend reporting that in your reporting synoptic reports or your cancer checklists. It does not in and of itself change the stage, but it is considered an adverse prognostic parameter by some oncologists. Another finding that's interesting in this particular case is that if you look at the rete testis here, you can see there are some areas with hyaline globule formation, like right here, for example. And if you know that yolk sac tumor frequently has hyaline globules, you might think, is this actually a mixed germ cell tumor with a component of yolk sac tumor? But actually, this is a phenomenon that's fairly well described in testicular germ cell tumors, that when they invade the rete testis, you sometimes have hyperplasia of the rete testis epithelium, and it often has hyaline globules, as you can see also in this field. So that was published quite a few years ago now by Dr. Albright from Indiana University, who was one of my mentors. So this is just something to be aware of, that when you have hyaline globules in a tumor like this, it may not be yolk sac tumor, it may actually be that embryonal carcinoma has invaded the rete testis. And for some reason, the rete testis has this hyperplastic proliferative response that frequently includes hyaline globules. So if that's the only evidence that you have that you're wondering about a yolk sac tumor, just think about that possibility and look at your slide at lower magnification whether this could be the rete testis. Here's another field where the epithelium is almost cribriform, but there are this focus of hyaline globules. Okay, so that's another example of embryonal carcinoma with some interesting stuff for thinking about the pathologic stage. Here is one other testicular germ cell tumor. And again, let's look at the normal tissue a little bit for some clues to what's going on here. So if you didn't have any background information, if you just picked up this slide and didn't know anything about it, and you looked at the adjacent seminiferous tubules here, you can see these look very different than what you normally see in the adult testis. So this is most likely a prepubertal testis, which gives you some clues to what type of germ cell tumor we might be dealing with here. So you can see the Sertoli cells are very monotonous. You have some germ cells, but other than that, we have really no maturation of the spermatogenesis. You just have these immature Sertoli cells and occasional scattered germ cells, but we don't have the typical maturation pattern that we expect in the adult testis. And we also don't have intratubular germ cell neoplasia or GCNAS, the precursor lesion that we expect to see in malignant germ cell tumors of the adult testis. So knowing that, we know that this is likely, just looking at the slide, a prepubertal testis. We can start looking at the tumor. And so when you think about germ cell tumors, a major change in the 2016 WHO classification was that prepubertal and postpubertal type tumors were split apart from each other into sort of two separate pathways of germ cell tumor development. So the postpubertal type, which we've been talking about so far in this session, are thought to be derived from the precursor lesion GCNAS that we talked about. Those are inherently malignant, and they frequently have molecularly the chromosomal gain of material from chromosome 12p. And frequently that manifests as isochromosome 12p, which means that you have the centromere of the chromosome 12, but then on both sides of the centromere, you have a duplicate copy of the short arm. So normally you have the P arm, which is the short arm, that comes from the French petite. So you have normally the P arm, the short arm, and then the Q arm, which is longer. But in the case of isochromosome 12p or iso-12p, you have the P arm duplicated on both sides of the centromere. So you have one centromere and two P arms instead of a centromere and a P and a Q. So that's the common molecular abnormality in malignant adult postpubertal type germ cell tumor. All the types really share that molecular abnormality of chromosome 12p gain. The prepubertal type of germ cell tumors, like the one that we're looking at here, do not have that same molecular pathogenesis, and they do not derive from the precursor GCNIS. And the two main types of prepubertal germ cell tumors that you can have are teratoma, pure teratoma, and pure yolk sac tumor. So in adults, it's quite rare to have a pure yolk sac tumor, but in prepubertal germ cell tumors, the two main types are frequently pure, and they are teratoma and yolk sac tumor. So you might be correctly jump to the conclusion then that this is most likely a pure yolk sac tumor in the prepubertal testis. And yolk sac tumor is kind of interesting in that it can have multiple patterns. If you look in any major pathology textbook that talks about the testis, you'll find a description of the many patterns of yolk sac tumor, but often it has this sort of reticular or net-like growth pattern with thin interconnecting strands of cells that form kind of a cribriform or a net-like growth pattern. As I mentioned in the example with the Reedy testis hyperplasia on the last slide, yolk sac tumors often do have hyaline globules. So for example, this is probably a hyaline globule. I'll move around to try to show some other areas, although it usually never fails in these type of slide seminars that you can't find focal findings like that when you're trying to show them. But here you can see some thin interconnecting strands of epithelial cells. There is some degree of cytologic atypia, but not as much pleomorphism as we would expect in an embryonal carcinoma like we just saw. Sometimes yolk sac tumor will also have deposition of basement membrane around it, so a kind of a hyaline basement membrane layer around it. Here's an example which is nearly solid. And something to keep in mind with the solid pattern of yolk sac tumor, one of my friends and colleagues, Sunny Kao from Stanford University, she published a few years ago that using immunohistochemistry, solid pattern of yolk sac tumor is often positive for c-KIT. So don't rely entirely on c-KIT if you're trying to distinguish seminoma from yolk sac tumor. Like in this field, for example, where we have solid yolk sac tumor, that could be positive for c-KIT. But fortunately, if you use markers like OCT3/4, OCT3/4 is typically negative in yolk sac tumor, so that combined with c-KIT could help you and resolve that differential diagnosis. And of course, in a prepubertal patient like this, a seminoma would be extremely unlikely or perhaps even impossible. So again, we've just got the reticular pattern of kind of interconnecting strands of cytoplasm with sort of a cribriform morphology in yolk sac tumor. And the morphology of yolk sac tumor is very similar whether you're talking about a prepubertal type or a postpubertal type. The only difference being that in postpubertal patients, there can be other admixed types of germ cell tumor, like, for example, embryonal carcinoma, seminoma. There can be GCNIS in the background. Whereas with prepubertal yolk sac tumor, usually those are pure, usually or always are pure. So I think this is a pretty good example of a prepubertal type of yolk sac tumor, likely occurring in a prepubertal child based on the adjacent testis that we looked at. Okay, so let's move on to the next case. This is a fragmented specimen, so something interesting must be going on here. This is unlikely to be an orchiectomy specimen given the way we see the fragmented nature of the tissue on the slide. So for example, this could be an incisional or excisional biopsy of a metastatic lesion, say in the retroperitoneum, which would be a common location for metastases of testicular germ cell tumors. But if we look at this, I'm sure that you very likely jump to the immediate conclusion that this is a teratoma based on the the heterogeneity of patterns that we're seeing here. We've got some glandular structures. As you can see here, a gland which looks kind of probably respiratory with cilia. You've got some nodules of cartilage here, some perhaps immature cartilage. And then here, this kind of spindle-shaped cells with sort of low cellularity. To me, this is most likely glial tissue. So basically, tissue resembling that of the brain. you have these glial cells and delicate fibrillary cytoplasmic processes. So this is sort of glial tissue in a teratoma. So teratomas are quite interesting in that they can have all sorts of varied morphologies depending on what types of tissues they're recapitulating from any of the tissue types, the ectoderm, mesoderm, endoderm, cell types. Here is another gland with sort of respiratory ciliated type epithelium. We move around some more. Here are some more glandular structures. Here's a little bit of probably mesenchymal tissue with some bone formation there. We've even got some calcification and bone formation. Let's keep moving around here. There's a bit more bone formation. Something that I think is easily overlooked in teratomas is that you also can have mesenchymal components. Like, for example, there's some smooth muscle here, and that's probably also even part of the teratoma, which, you know, sometimes we probably just kind of glaze past it when we're thinking that that's a normal structure. But I have seen large areas of smooth muscle as part of a testicular mixed germ cell tumor, and I've seen that occasionally overlooked, where the original pathologist thought that it was a pure seminoma, ignoring large areas of smooth muscle, which are likely a teratomatous component. So that's something to be aware of. And so when we talk about, again, the prepubertal versus postpubertal types of testicular germ cell tumors, it's important to remember that everything in the postpubertal group of tumors is considered inherently malignant. You know, these are, again, derived from the GCNIS precursor. Here's a large area of smooth muscle, like I was just talking about, and some glandular structures. Some of these glandular structures might even have a slight amount of cytologic atypia. That doesn't necessarily mean anything, although it does, you know, support being a teratoma of the malignant pathway rather than a benign teratoma like you can see in the prepubertal testis. And so, again, we're talking about the prepubertal versus postpubertal teratomas. If you have a patient with a postpubertal patient who has an apparently pure teratoma in the testis, you don't see any other components, it's important to remember that most of those, the vast majority, are malignant, despite being a quote-unquote pure teratoma. And some of the clues to recognize a post-pubertal type of teratoma, aka a malignant one, is that the elements are often very haphazard. You don't have as much of an organoid architecture where you have sort of a central lumen and glandular structures feeding into that lumen and smooth muscle arranged around the around the wall of that structure. If you have cytologic atypia, that's basically incompatible with a benign prepubertal type of teratoma. If you have GCNIS, germ cell neoplasia in situ, in the background, again, that's almost incompatible with the diagnosis of a prepubertal benign type of germ cell tumor, or I guess I would say it's fully incompatible with that diagnosis. And if you have the opportunity to do molecular studies and you find the isochromosome 12p, that also is basically incompatible with the benign prepubertal type of germ cell tumor. And so you might wonder, well, why am I emphasizing this, since we can just look at the age of the patient and know whether they are pre or post-pubertal? And the reason I'm emphasizing it is that very rarely you can have prepubertal type teratomas in a post-pubertal person. So, you know, say, for example, you have an adult male who's 20 or 25 years old. Rarely that patient can have a prepubertal type of teratoma. And you have to go through those strict criteria that I just mentioned. So it really should have no atypia. It should have an organoid architecture. You should have no germ cell neoplasia in situ in the background. You should have good spermatogenesis in the background. So if you have abnormal impaired spermatogenesis, that is an argument that you have an abnormal testicular environment, and most likely that would be in keeping with a malignant germ cell tumor. You should not have microlithiasis or calcifications in the background seminiferous tubules, because again, that implies an abnormal testicular environment that is more in keeping with a malignant type of germ cell tumor. So most of the time, the distinction between prepubertal and postpubertal is somewhat obvious based on the age of the patient and if you look at the background testis. But just to point out that rarely you can have a benign teratoma in an adult patient, and you have to use those very strict criteria that you can have none of those things. Often those will be in the form of a dermoid cyst, so you have just a squamous line cyst with glands draining into it, or an epidermoid cyst with just a squamous line cyst and no other elements. Those are the most common types of prepubertal type teratomas that you could see in an adult patient. But rarely you can have other types of glandular epithelium as well, like for example, respiratory type glandular tissue. But again, any atypia, the haphazard architecture, GCNAS, or any of those things that I mentioned would argue against a prepubertal type of teratoma. And so something to remember is that, even if a patient has an orchiectomy for a pure, quote unquote, pure teratoma, it is still possible that that patient could have metastases of a different type of germ cell tumor. So for example, seminoma or embryonal carcinoma and so forth, because the thinking is that most likely what happened is that you had GCNAS, it evolved into teratoma or other subtypes of germ cell tumor, which then evolved into teratoma. And then some of those things, say, for example, seminoma or an embryonal carcinoma, they metastasized, and then whatever is left in the testis just matured into teratoma. And so again, use those very restrictive criteria. Even if you have what looks like a pure teratoma in the adult male testis, it doesn't matter if it's mature or not. If you have any of those things, atypia, GCNAS, abnormal spermatogenesis, you should interpret that as a postpubertal type of teratoma, and maybe even make a comment to your clinician that despite being a quote-unquote pure teratoma, this is likely malignant and the patient should be staged. In other words, they should have imaging studies or serum tumor markers to look at their retroperitoneum for metastases. So that can be sort of confusing, but I hope I was able to emphasize the difference between prepubertal and postpubertal type of tumors, which is a new change in the 2016 WHO classification. Okay, so for the next case, this is a paratesticular mass, and I suspect that this sample was used for frozen section because it has a little bit, I think, of frozen section artifact on it. But if you know that, this is probably one of the more common issues that you'll receive for testicular or especially paratesticular frozen section diagnosis in the testis. So if you look at this, we've got these kind of glandular looking structures here, and some of them, if you look carefully, have these strands of cytoplasm that are bridging across the lumen. So I'll move around and show some examples of that. Here's another one, kind of a glandular structure with these thin strands of cytoplasm that are bridging across the lumen. If we look over here, there's kind of an almost cribriform looking glandular structure with these strands of cytoplasm. Move around a little bit more. Here is a really good field right in the center where you have a glandular structure and then this bridge of cytoplasm that's reaching across. And so probably you've correctly jumped to the conclusion that this is a paratesticular adenomatoid tumor. And adenomatoid tumor is the most common paratesticular tumor, and so it's very helpful to know about this for frozen section purposes. If your urologist is aware that you have a lesion that's just in the paratestis and not not within the testis itself, then they might take a biopsy or an excisional biopsy or an incisional biopsy of this and submit it for frozen section, in which case, if you're able to correctly diagnose it as an adenomatoid tumor, you can spare that patient from having to have a radical orchiectomy where the entire testis is removed. But again, I think this is a good example of adenomatoid tumor. The important thing to remember about these is that this is a mesothelial proliferation. And so if you use your common mesothelial immunohistochemical markers, that can help you to confirm the diagnosis. So they will be positive for cytokeratin immunohistochemistry. But if you use mesothelial markers like, say, WT1 or calretinin and so forth, that will be frequently positive, high molecular weight cytokeratin and others. That can help you to confirm the mesothelial origin of this proliferation if the case is morphologically difficult. A couple of things to remember that can be confusing is that although this is typically a paratesticular mass, that is in the hilar tissue of the testis, occasionally they can extend into the testicular parenchyma, so that can be potentially confusing. And another potentially deceptive feature is that they can occasionally have necrosis. So in and of itself, having necrosis doesn't mean that it's necessarily malignant. If you have otherwise the typical features around the periphery of an adenomatoid tumor, you can still make that diagnosis, even in the face of necrosis. And very recently, a study was just published in Modern Pathology, which showed that many of these have mutations in a gene called TRAF7, TRAF7, is frequently mutated in adenomatoid tumors, both of the male and female genital tract. And this finding of the threads of cytoplasm that are kind of bridging across the lumen of the glandular structures. That was described in a very nice paper by a friend and collaborator of mine, Dr. Andra Hess from the Czech Republic, under the name thread-like bridging strands. So that's a feature that is very consistently positive in adenomatoid tumor, this bridging strands of cytoplasm that go across the lumen of the gland, and that can help you with your diagnosis, especially if you're encountering a case on a frozen section like this one. Here's an example of a prostate needle biopsy specimen, and so let's go along the length of this biopsy specimen to evaluate it. I thought this was an interesting case to include in the seminar because you have this sort of atypical glandular proliferation here, but if you look at these glands, many of them have nuclei that are somewhat cytologically bland. So we don't see the typical large nuclei with nucleoli that we see in prostate cancer everywhere in this biopsy, but we do see it kind of focally, and I'll show you some areas. So I think this to me is an example of what you might call foamy gland variant of prostate cancer. If we go here, for example, you can see these large glandular structures, some of which are sort of becoming almost cribriform. Like for example, this one here, you can see it's got at least a structure bridging across the lumen with possibly an additional small lumen. But then if we look at it at higher magnification, many of those nuclei are very small, almost like lymphocyte type nuclei. So they don't have the big nucleoli that we see normally in prostate cancer. And so this is something to remember about the foamy gland variant of prostate cancer, that although the nuclei are often very small and punctate like this, if you look around carefully, you'll often find other areas with the more typical nuclei of conventional prostate cancer. So like in this gland, for example, several of these nuclei here are very small, condensed nuclei like lymphocyte nuclei, but we start to look at this edge, they're a bit bigger like those of typical prostate cancer. And I'll move along here and show some other areas that hopefully illustrate that a little bit better. But again, this is the thing to just to remember about the foamy gland variant of prostate cancer, is that the cytoplasm in these tumors is very foamy, and many of the nuclei are small, so they don't have the typical nuclear features of prostate cancer. But if you look at it carefully, usually you will find some other areas that do have typical nuclear features. So right here, for example, we see a couple of glands that have more typical nuclear features of prostate cancer. If you are really struggling with a case like this, you can use immunohistochemistry. And even the cells that look deceptively bland, they usually will have a prostate cancer type staining pattern using immunohistochemistry with absence of basal cells and prominent staining for AMACR, AMACR, or alpha methyl acyl CoA racemase. So I thought this was a good example of just potentially deceptive variant of prostate cancer where the nuclei are not that atypical. But if you look around, usually if you have a large enough area of tumor to look at, you'll find some areas with typical nuclear features of prostate cancer. Here actually is a cribriform structure, which again should not only make you more suspicious that this is cancer, but also should point towards a higher grade. So this, I would likely grade this tumor as a 3 + 4 = 7, or grade group 2 prostate cancer due to focal cribriforming and focal glandular fusion. So that's a good example of foamy gland variant of prostate cancer. Nuclei are very small often, and the cytoplasm is very foamy, so that differs a lot from the typical prostate cancer. But if you're in trouble, you can use immunohistochemistry, and that usually will help you. Here is an adrenal mass. If we look over here, you can see some normal adrenal tissue with the very vacuolated cortical cells here, and then more eosinophilic cortical cells. In this particular area, we don't really have very much medullary tissue, but then as we progress over here toward the center of the adrenal gland, you have medullary tissue composed of these cells with the blue-gray amphiphilic cytoplasm, and that'll be very relevant to what we're about to look at in the tumor itself. Something that I often like to point out about the adrenal gland when I'm working with trainees is that the adrenal vein, which runs through the middle of the adrenal gland, often the adrenal tissue kind of goes right up to the adrenal vein. Here you can see some of the muscle of the wall of the adrenal vein. And then as we go over here, you've got adrenal cortical and medullary tissue that's almost abutting the endothelium of the vein without any significant muscle. And so that's a kind of an unusual anatomic feature of the vasculature of the adrenal, that even normal tissue can almost touch the endothelium, or almost looks like vascular invasion. And so as we'll talk about in a few minutes, since even normal tissue can almost quote unquote invade blood vessels, there are not great criteria in the adrenal gland for predicting malignant behavior. You might think that vascular invasion would predict malignant behavior, but even since normal tissue can almost do that, there are no great criteria for predicting malignancy in adrenal tumors, whether we're talking about cortical tumors or pheochromocytomas. And so this is an example of a pheochromocytoma of the adrenal gland. If you look at this area, for example, we have the very classic nested pattern, or the buzzword that you might be familiar with is the Zellballen pattern of pheochromocytoma, where you have these discrete packets of cells. And something to me that I think is very helpful for pheochromocytoma is that these cells have this very blue-gray amphiphilic cytoplasm. And when you see that, to me, there's almost nothing else that will have that color of the cytoplasm, the kind of this blue-gray appearance. Here's a good field which really shows that packeting of the cells into small nests, or the so-called Zellballen pattern. And in this particular case, if you spent any time looking at it before this, you might notice that there are areas with a whole lot of cytologic atypia in the same specimen. So here we have some big giant tumor cells, with this one having multiple intranuclear cytoplasmic invaginations or cytoplasmic inclusions. Here's another big nucleus with two large intranuclear cytoplasmic invaginations. It's certainly possible that you can have this degree of pleomorphism in a pheochromocytoma. And if you look into the literature on these, you might find that there are some various proposals for criteria to predict the malignant behavior of pheochromocytomas. One that's fairly well known and fairly popular is the PASS, P-A-S-S system, which stands for pheochromocytoma of the adrenal gland scaled score. And so any of these, that system or any other system that's been proposed for predicting malignant behavior tries to use different morphologic criteria such as vascular invasion or necrosis or pleomorphism or mitotic activity or cellularity or various things to attempt to predict malignant behavior of these tumors. But in general, to my understanding and to my discussion with colleagues who are specialists in endocrine pathology, there's really no good agreement that any system is very predictive of malignant behavior, either in pheochromocytoma or in adrenal cortical tumors. And so currently in practice, I typically do not implement any scoring system routinely. I sometimes will put features such as the mitotic rate in my microscopic description in case anybody's looking for that, or I might mention that there's no suspicious findings such as vascular invasion or extra adrenal soft tissue invasion. But I usually put a comment indicating that in the absence of metastases, there really are no great criteria to predict malignant behavior in pheochromocytoma. Just to let clinicians know that we really have no good way of predicting those that will be malignant. So I think this is a pretty good example of a pheochromocytoma. It has these patchy areas of substantial atypia. If you were trying to use one of these scoring systems, I think this would qualify for atypia. But at least my current stance on this and what I've gathered from speaking to endocrine experts is that there's really not a requirement to do any of these scoring systems right now, as they've not been proven to predict the malignant behavior of pheochromocytoma very well. And then finally, I believe this is the last case. We have a bladder biopsy. And if you look at this biopsy, you can see that you've got this sort of proliferation of urothelial cells. It might bother you a little bit when you're looking at it that you have, say, this cluster of urothelium that's dipping down from the surface, or over here you've got some infoldings where the epithelium is kind of pinching down and going down deeper into the stroma. And you might wonder whether this is some degree of atypia, or is that even an early carcinoma. But something to be aware of in the bladder is that when you have radiation changes, you can have this phenomenon known as pseudocarcinomatous hyperplasia, where the epithelium begins to dip down and create this atypical finding that almost resembles invasive carcinoma. And the clue that you're dealing with pseudocarcinomatous hyperplasia is that you have these, often you have this layer of fibrin around the epithelial cells and around the blood vessels. So here's a blood vessel, a dilated blood vessel, and you've got this layer of fibrin just outside of it in the wall. And over here, for example, you've got the epithelium, and then you also have this fibrin accumulation underneath. And so that is a clue that you're dealing with radiation, cystitis, or pseudocarcinomatous hyperplasia. Those two things basically go hand in hand. Almost the vast majority of patients with the entity pseudocarcinomatous hyperplasia have been treated with radiation, usually for prostate cancer. However, some of the studies that have looked at this process have found occasional patients with other associations, like, say, severe vascular disease or sickle cell disease. In other words, they have something that would likely cause vascular injury and could be resulting in this pattern in the bladder. But this particular slide was labeled as a patient who had radiation cystitis. And in this particular one, it may not be that florid to the point that it mimics an invasive carcinoma, but it is something to be aware of, that you can have this pseudocarcinomatous proliferation of the epithelium that's often found after radiation. And the clue to that is that you have dilated blood vessels with fibrin wrapping around them. And that can also be, the fibrin can also be wrapping around the invaginations of the epithelial cells. So that is the last case in the slide seminar. I appreciate your tuning in and to be part of this review course. If you have any questions or anything that I can do to help, my contact information should be on the course materials. And thanks again for tuning in. Thanks to Dr. Singh and the members of PathPresenter for having this course.